All right. Welcome, everybody, to Cardiovascular Medicine Grand Rounds. It is my great honor to introduce today's speaker, Dr. Kim Eagle, who is the Albion Hewlett Professor of Internal Medicine and Director of the Cardiovascular Center at the University of Michigan. He graduated from Bozeman Senior High School in Montana, and he then attended Oregon State University, graduating in 1976, followed by Tufts University Medical School. And he then completed residency and chief residency in internal medicine at Yale New Haven Hospital, followed by research and clinical fellowships in cardiology and health service research at Harvard Medical School. He served MGH as the Associate Director of Clinical Cardiology and Associate Professor of Harvard Medical School before he moved to Ann Arbor and joined the University of Michigan. At U of M, Dr. Eagle developed an outcomes research program that focused on quality, cost effectiveness, practice guidelines, treatment of aortic diseases, and the fights against childhood obesity. He's the founder of Project Healthy Schools and the reuse of pacemakers in third world nations. He's the founder of Project My Heart, Your Heart. And his research has led to multiple initiatives in Michigan that have impacted the nation. He's the editor of the ACC website, acc.org. He received the ACC's Master's denomination, also the Distinguished Teacher Award in 2012. In 2018, he received the American College of Cardiology Distinguished Scientific Award in the clinical domain. Things that you may not know about Dr. Eagle: he's a past president of the Ann Arbor Symphony Orchestra, and he's an avid fly fisherman and skier. He enjoys going to Montana, his childhood home. For those of you who don't know Dr. Eagle on a more personal level, he's a passionate clinician, a passionate educator, and a mentor for all of us. So we're excited to hear your talk.
Thank you. Good afternoon. Can you hear me? Thank you for sharing lunch today. So I'm going to take you on a journey through my walk with this topic, cardiac risk of non-cardiac surgery. I don't have anything to disclose, I don't think. Let's see if I can advance it.
Go ahead.
There we go. Okay. So this is my lecture outline. I will start with a rant, and then I'll talk about a lesson in history, a lesson in research. I'll get fairly personal here about some things that I studied and wrote. I can't take it all back, but some of it I might. And then a personal reflection. So this is my rant, and my inbox every day in clinic has about 5 of these. Clear this patient for surgery. Like I'm a clearance house. And occasionally, there's a rude statement like failure to do this quickly might lead to having your surgery canceled. Like, thank you very much. I just love that. When I clear a patient, sometimes I think I'm offering my name as the malpractice target if things don't go well. You know, it does occasionally get me. For a while, I wouldn't do it. I'd say I'm not a clearance house. I'll comment on risk and what we might do to mitigate risk, but I've caved. You know, you get old enough and you sort of say, yeah, it's time. Okay, pre-op clearance, I don't need that. My doctor tells me I'm the healthiest president in US history. Pre-op clearance is for losers. I'm not making a political statement, but clearance definitely has my attention. So I think it's always useful to look back where you came from. And this guy's looking back for sure. So historically, Lee Goldman in 1977 really advanced the notion of preoperative clearance with a study at MGH looking at markers of risk, non-cardiac surgery, cardiac risk. And there are things that are self-evident: heart failure, MI, arrhythmia, age, high-risk surgery, things like that. Alan Detsky then really did a nice advance looking at the type of operation, aortic valve disease, angina, heart failure. In the 80s, when I started studying this, there was an interesting moment when we started thinking about using stress testing to refine risk estimates. So I was studying Bayesian theory at Harvard School of Public Health and how to read diprotomal thallium nuclear scans at the hospital. A perfect moment to ask the question, how do we use clinical reasoning and test results to refine our risk estimates? And then Tom Lee, I think, create the revised cardiac risk estimate, which I think many of us use, and I do too. It's on the right here. And we'll take a look at some of these. So chance favors a prepared mind. And I was in a perfect moment to ask the question, how do we combine patients' clinical history and test results to see who's really at risk and maybe who is not at risk? I had a mentor, Danny Singer, and I said to him, you know, what I'd like to do is take patients who have vascular surgery, and my bet is that they don't have any of those things, angina, MI, heart failure, diabetes, or a Q wave. They're probably going to do okay with vascular surgery, regardless of a test result. I think they're going to be low risk. That's over here on the left side. I studied 29 patients who had no markers, and none of them had a perioperative MI or death. But in the group that had a stress test over here, you see those that had a ischemic result, the events were there. I said to Danny, I think I want to send this in for publication. He said, that's a joke. I said, what? He said, you developed your theory on that data set. You have to validate it. Besides that, it's not enough. There's not enough patients here. So I said, okay, I'll study another 50 consecutive patients, same markers of risk. If they had none, and they had the surgery, no events, even though 6 of them had a stress test that was positive. Here's the group that had 1 or more markers. If you had ischemia, 8 events, and all the MIs and deaths were there. My mentor said to me, still not enough. I said, I don't agree. I think we should submit this, which I did, and it got in a week. Why? It's simple. It's simple clinical reasoning, and we're always looking for simple. There's so much complexity. A simple logic. Low risk is low risk. So this is the algorithm that I use in my head when I think about preoperative risk. I think about the clinical markers a patient has. How much do they do in their daily life? What is the surgery-specific risk? And taking those then leads to this branch point. You can call it clearance if you want, but it's okay to proceed, or I'm concerned. Either I need to change therapy or perhaps testing may be revealing here. This is sort of how we think about perioperative risk today. Always make things as simple as possible. So guidelines can be very useful in this regard. And the revised cardiac risk index includes the type of surgery, ischemic heart disease, a history of heart failure, cerebrovascular disease, preoperative insulin therapy, diabetics, and elevated creatinine. Very simple 6-item tool that we can use in the clinic. And if you look at the risk of events, non-cardiac surgery, what you see is the number of those markers go up, the event rates are almost linear. And this is not a small study like Kim Eagle published. That's 10 million patients. It's a lot of patients. Okay. So then we ask the question, well, how does preoperative assessment actually help patients? And it's here, right? We find and we treat systolic heart failure. We find and we treat unstable or previously unknown coronary disease. We find and we treat important arrhythmias. Ditto valve disease. Maybe stable ischemic heart disease. We'll talk about that. And sometimes the best thing we can do is cancel an operation that might be unnecessary in a high-risk patient. You know, you get the patient who's got claudication, and suddenly you're talking about doing a heart cath to define their anatomy. And they're saying, you know, my leg's feeling better. Maybe I don't need that. Functional status is so important. What patients do in their daily life really determines perioperative risk. Paul Dudley White, who founded the cardiac unit at Mass General in the 1920s, was once asked, how do you estimate cardiac risk? And he said, I walk patients up 2 flights of stairs and down. I measure their heart rate, their blood pressure, and their respiratory rate. And if they're labored, I'm worried. Patients who don't do much in daily life worry us because we don't know what their cardiovascular reserve is. Patients like you who work out every day for an hour like I do, you'll rock through most non-cardiac surgery unless there's a big problem. I mean, if you bleed to a hemoglobin of 9, you might have a problem, but active patients generally do very well. This is a simple study which asked a group of patients, can you walk 4 blocks or up 2 flights of stairs? And the answer to that was, no, I can't do it. Their perioperative complication rate was twice the group that could. So functional status is so important. Markers, functional status, surgery-specific risk. We typically say that if you could do 4 METs or more, that's great. 1 MET is simply sitting here listening to Kim Eagle, maybe a little bit of a point for eating. If you could do yard work, sex is about 5 METs generally. And certainly if you can run short distances without trouble, those patients rock through most non-cardiac surgery unless there's a big problem. Okay. This is an important slide, probably the most important take-home message, number 1. Having a recent stroke is a really important risk factor for cardiac events after non-cardiac surgery. Having a stroke affects cardiac risk. And if you look at all-cause mortality, if you've had a stroke within 3 months, the hazard rate of that is way up there. It's like 3 or 4-fold higher. And what's happened here is that having a stroke alters the basic vascular biology of our bodies. And we get inflammation that can affect coronary risk as well. David knows this because he studies it. So when you have a patient in front of you who's had a recent stroke, anticipating a gallbladder, wait at least 3 months, preferably at least 6 months for that process to heal. Surgery-specific risk is the subject of this slide, and this shows you the type of surgery and the overall rates of events. And vascular and thoracic transplants are on the left with neurosurgery, they're highest risk. Over on this side, you know, a lumpectomy or a thyroid operation, super low risk, right? Cataract repair, what I call eye dentistry, $1,000 a pop, low risk. High revenue, but low risk procedure. This slide's important because it illustrates what Dr. Henke and other vascular surgeons know, and that is that even though peripheral vascular repair feels like a simpler operation than maybe doing a big aortic operation, the risk is equivalent to aortic aneurysm surgery. And the reason is, at least partially, that patients who have peripheral arterial disease often have diffuse atherosclerosis, also involving their heart. And an amputation is not a low-risk operation because it's happening in a very high-risk patient, okay? Knee surgery has a very low perioperative mortality. This is the national database from England, and the mortality at 30 days was 0.6%. I don't know what I can do to lower that risk. And that's low risk. We probably shouldn't be doing preoperative screening of the heart in patients having such low risk surgery that they never have events. So here it is then in a nutshell: markers of risk, functional status, surgery specific risk. It's very straightforward. If you want to get more complicated, you can go online. This is the NSQIP risk calculator that has about 20 variables, performs very well. It is slightly better than that simple revised cardiac risk index. I have a couple of astrophysicists in my practice. They definitely want to go through this. All right. There's an updated marker or risk marker a few years ago, the cardiovascular risk indicator, which is shown here. They added anemia to the story. And that it had a very good derivation, performed similar to the revised cardiac risk index. Okay, so what's the most important preoperative test of all? A history and physical. Kim Eagle's been studying this for almost 35 years. And he's standing here saying the best test you can do is a great history and physical. And not infrequently, you're the only one who will do that. But it has to be a good history and physical. I don't ask you, do you have angina? If I just say, do you have chest pain and you deny it and I stop, I haven't done my job. I'll then say, okay, what's the most vigorous thing you do in your life? Oh, I take out the garbage and it's a long walk to the alley. Oh, okay. How heavy are the bags? 30, 40 pounds. What happens when you do that? Well, interesting. I get this jaw discomfort. What do you think that is? Angina. So we have to ask patients what they do in daily life to try that, then ascertain, okay, how do you feel when you do that? And if they say, well, I'm really out of breath. Oh, I asked you if you had shortness of breath. Well, I didn't. I thought you meant at rest. Oh no, when I bring those big bags for the salt thing, you know, they're 40 pounds. I'm terribly short of breath. I stop every 5 feet. Uh-oh. So the history and the physical have to be thorough. But if you do that and an EKG, you usually get the critical information that's so important. We're looking for new or unstable coronary syndromes. We're looking for heart failure, particularly poorly compensated. We're looking for symptomatic arrhythmias. And with our exam, we especially don't want to miss important aortic valve stenosis. Don't want to miss that. And the patient may not know. They're a farmer from Muskegon. They've never seen a doctor. You're the first. And if you don't listen to their heart, you miss it. So for ischemic symptoms, of course, functional class, recent MI is especially troubling within a few months. Have they been revascularized? What's the type of stent? How much hardware do they have? Is it a bifurcation? And have they been evaluated before? These are all logical things that we want to make sure we do every time. So heart failure is really important because we must understand the physiology of it. In the preoperative moment, you can't assume their heart failure is HFrEF, heart failure with reduced ejection fraction. Don't you love cardiologists? All of these acronyms we have. HFrEF, HFpEF, HOCM. What's that? Heart failure with preserved ejection fraction, the approach to that is different than reduced ejection fraction. And obstructive cardiomyopathy is especially one you must find. Why? So if Victor has obstruction and he gets into trouble post-operatively, and I decide to diurese him, he may get worse. If I give him digitalis, he'll get worse. So we have to understand why they have heart failure before they go into big operations, because with all the fluid shifts going on, they are very prone to have heart failure. If you don't know the physiology of their underlying heart muscle disease, you're in trouble. You're really in trouble. We know that if you have heart failure with severely reduced ejection fraction, your hazard risk is about 2.3. And symptomatic heart failure, much more risk than asymptomatic heart failure. Okay, so let's think about coronary disease. Now, when I was training, we thought that this was basically all about the plumbing of the heart, and that if we could find coronary blockages and fix them, that patients would do better, right? I mean, if the motor has pipes and the pipes are obstructed, fix the pipes. That's what we thought. And so we sought to prove it. But interestingly, if you look at how accurate our testing is to predict events, it wasn't so good. This study here, if we looked at dobutamine stress echo, about 85% sensitive. Stress thallium imaging was about 83%. So we were missing 1 out of 6 who was going to have an event. And the specificity was also poor. And if you looked at the positive predictive value, this is a study we did looking at thallium testing. If you had ischemia, only 1 patient out of 8 had an event. So, geez, how much are we willing to pay to try to prevent 1 out of 8? Stress echo was a little better. It was about 20% positive predictive value, only 1 out of 5. So our testing had a lot to be desired. It's not like you have ischemia, you're going to have an event. Most of the time you didn't. Okay, well, that's interesting. And then it gets at the question, if you're going to do a test on a patient pre-op, what type of test would you do? And my argument would be do an exercise test if you can. Because if you look at stress testing, what variable on a stress test predicts mortality best? It's not the left ventricular function. It's not the EKG. It's how long you walk on the treadmill. Best predictor of mortality. So why not do an exercise test? The other thing you get is if the patient gets ischemic, you know at what heart rate and blood pressure they do. That may be useful to the perioperative team. Say, I'm gonna try to keep his heart rate below that threshold because I think he's less likely to have trouble. Okay? If you're trying to look at valve disease too, an echo with a stress test. If you're looking to quantify muscle, then myocardial perfusion imaging with SPECT or PET would be great. Echo probably has fewer false positives because with echo, you have to get half the thickness of the heart muscle ischemic before the wall will stop moving properly. Whereas with myocardial perfusion imaging, we can see subendocardial ischemia that's not even half the thickness of the ventricle. So if you're trying to avoid false positive, echo is probably better. Okay. Coronary CT, increased coronary artery burden predicts risk. If you have, triple vessel disease, hazard rate of about 5.2. So more heart disease, more risk. I'm not sure how much that helps us, but it's true. And now let's have this lesson in history. How many of you remember Reverend Bayes? Whoa, 1 of you, 2 of you. So Reverend Bayes was a reverend by day and a mathematician by night. And he believed that if you think about a population, then they're going to have something like heart surgery or non-cardiac surgery. The overall likelihood of a population of patients is an important part of estimating risk. And then if you apply a test, you have to anchor it in the overall likelihood of the population. These are young, healthy people. I can tell you all work out and your overall risk is low. And so if I give you all a test and one of them's positive, it may be a false positive because you're healthy and the tests are imperfect. That's the notion of Bayes' theorem. What's the population you're studying? Apply a test result. So you have a baseline probability, test, and a revised probability, right? That makes sense? So here's Bayes' theorem in action. This is a study we published in the 90s. We took about 1,000 patients having major vascular surgery. These were AAAs predominantly. We used the Eagle markers to define them into low clinical, moderate, or high risk. High risk are patients with 3 or more markers. Low risk, no markers at all. They all had a stress test. And they all went to surgery. And then we looked back and said, okay, in the low risk group, what happened? And you look here, and here's the stress test, and it's defined into low, moderate, or high risk test based on the amount of ischemia. And look at the events. In the high risk group, there were no events. Huh. What's going on with that? Reverend Bayes would say, I told you, low risk is low risk. You didn't need to test. And in fact, if anything, the test confused you. Now there's this high risk group out here, right? This is, they start with a risk of about 18%. This is Peter Hankey calling me on a Friday afternoon saying, listen, I wanted to let you know about one of your patients. Sure, what's going on? Well, her name is Grace. Middle name is Hope. She's 85. She has angina and diabetes and a little bit of heart failure. And we're doing a little fem-pop bypass on her tomorrow. Is she symptomatic? Well, she does describe a little tightness when she brushes her teeth. Well, Grace is high risk. And even if her stress test was normal, 1 out of 8, heart attack or death. And that group is high enough risk that you might decide, I'm not sure the test is that valuable. I know they're high risk. I have to work with Peter to decide, does she need it? Does she really need the surgery? Or is she optimized from a medical point of view? In this particular study, it was the in-between group, the moderate risk. These are patients who had 1 or 2 of the markers I talked about, angina, diabetes. If their test was very positive, 1 out of 5 had heart attack or death. And if it was low risk test, it was 3%. So that range from 3 to 20%, that's a big shift. That's a group where the test result might influence what you do. You might say, your AAA is 5.3. It was a borderline call whether we need to do it anyway. Your risk is pretty high. Let's just kind of watch that thing. So this is Bayes' theorem in action. And we relearn Bayes' theorem with every test we do, right? Just ask our fellows about chasing troponin. Yeah. So if you think about current medical care in our country, there are a variety of things that we overdo, and over-testing, cardiovascular testing in low-risk patients is something we do way too much of. And I'm not convinced it helps. And I think sometimes it hurts. Do you need a pre-op consult for a cataract? The risk of walking into the CVC is greater than a cataract operation, especially with the construction. And yet, if you looked from 95 to 2006, the number of pre-op consults for cataract repair went up and up and up. Oh my goodness, what are we doing? So if you think about testing, what are we finding when we do test for coronary heart disease. If you ask what causes perioperative heart attacks, catechol surges, there's a prothrombotic environment, there's blood loss, there's fluid shifts, there's perhaps coronary plaque destabilization, and then there's fixed coronary disease. That's the only one of those that stress testing can predict. The other 5 are not predicted. And we were interested in looking at who has fatal postoperative MIs. And we were thinking about, okay, what happens perioperatively? Well, the catechol surges are big. This is norepinephrine and epinephrine. So you see this epinephrine spike in the morning hours when you do operations. Norepinephrine stays up for days after major vascular surgery. And we found, we were doing a study looking at coronary anatomy, and we were able to find 42 patients who suffered a fatal postoperative heart attack after non-cardiac surgery, who had very good coronary pathology. So we looked through their pathology and found that about 20% of them had left main disease. Most of the rest had significant triple vessel disease. Most of the rest had 2 vessel disease with involvement of the LAD. 2 of them had no disease. They were both women in their 50s. They suffered fatal postoperative anterior wall MIs. This was Takotsubo before Takotsubo existed. They probably had a stress-induced cardiomyopathy from their surgery. They had an MI. This was a young man who had a gallbladder operation. And his postmortem showed about a 50% proximal right coronary that ruptured, the plaque ruptured. He infarcted his right ventricle. We wouldn't have found him with a preoperative test. I remember after we published this, I got a call from a fellow who's at Stanford. He said, Dr. Eagle, I wanted you to know that your algorithms don't work. I said, that's nice of you to call. Thanks. Tell me about the patient. 45-year-old man with risk factors, had a normal stress test, post-op, had a fatal MI. His path showed about a 30% left main and a plaque rupture, infarcted his whole left ventricle. We don't know how to find those. We're far from being able to say, David has a vulnerable plaque, we should do something about it. We're working on it, but we're not there. So we'll never find all of these high-risk patients. We just can't. All right, so let's talk about the journey with therapies to reduce risk. We'll talk about beta blockers, statins, aspirin, clonidine, and hemodynamic monitoring if there's time. How are we doing for time? Okay. All right, so the story with beta blockers got started by Dennis Mangano, who showed that patients who were having vascular surgery who were given beta blockers preoperatively and after appeared to have an improvement in outcome. This led to this study called DECREASE, where patients having elective aortic surgery with clinical markers of risk had a stress test with ischemia, got randomized to beta blockers or placebo. And guess what? The beta blocker group did much better. Wow, look at that. If you're a math major, that's about an 85% risk reduction from beta blockers. I actually don't know of anything in cardiology that comes close to that. Do you? I mean, parachutes are probably, you know, parachute versus placebo, that big of a difference, but geez, that's a lot. Just tuck that away. And what he also showed was that if you go into the operating room with a heart rate under 65, you do better. So Poldermans from the Netherlands was pushing the notion that beta blockers should be very commonly used. I always like to use a new drug before its effectiveness wears off. And so Lindenauer did a study of the Medicare database showing that, if anything, the benefit of beta blockers perioperatively was pretty modest, maybe a 10% risk reduction, not 85%. And in fact, he showed that if you just treated diabetics with beta blockers, if you treated 209, you'd cause a death. This isn't number needed to help, it's the number needed to hurt. And only when you had like a score of 4, who was that? Heart failure, prior MI, diabetic. A lot of those patients should be on a beta blocker anyway, right? So this gave us a potential glimpse of trouble with routine use of beta blockers. Believe it or not, I was on a committee that was deciding whether we should offer beta blockers to every patient having non-cardiac surgery in this country. Every patient. And in fact, should it be a quality measure? Should you be graded down if you didn't give beta blockers to everybody? Wow. So one of the first duties of the physician is to educate the masses not to take medicines. This study, which was based on the Polderman's article, the investigators said, well, we're going to randomize 8,500 patients. And if Polderman showed that effective beta blocker is really important, we're going to give them a lot. We'll give them 100 milligrams the night before, and we'll repeat it if we need to the morning of. Versus placebo. They called us and said, this is Richard Devereaux, do you want to participate? I said, there's no way I would give a patient 100 milligrams of Toprol who's never seen it. How much Toprol do you start in clinic? 25? Really? Whoa. So the primary endpoint was the combined death, MI, cardiac arrest, and it slightly favored Toprol. There was, however, a secondary endpoint, and that was called counting the bodies. And that did not favor. Metoprolol caused a higher mortality, statistically significant higher mortality. If you get into trouble perioperatively, you're bleeding or you're septic, how does your body get you out of that? Heart rate, the amount of myocardial squeeze you have. You need a high cardiac output to overcome anemia or fever. If you paralyze that, the organism can't get out of the hole. That's what beta blockers did. And if you treat 1,000 patients, you prevent some MIs and revascularization, but at the risk of deaths and stroke. Boy, am I glad we didn't give everybody in this nation beta blockers before non-cardiac surgery. And we were this close to doing that. The predictors of risk, of course, if you have a stroke or you get hypotensive. And this is what was happening in that trial. If you look at the question, okay, well, who does benefit from perioperative beta blockers? They're patients that you and I are already treating. They have systolic heart failure or a recent MI. That group should have been on a beta blocker anyway, and they probably benefit. There's a little risk, but overall, there's probably some benefit. So I'm going to go by this just in the interest of time. So patients who have coronary disease, hypertension, heart failure, they should be on them. Maybe some patients who are having high-risk markers, perhaps if they have hypertension, particularly recent MI, yes. Systolic heart failure, yes. What about statins? Statins in patients with atherosclerosis lower your risk of having an MI or death after non-cardiac surgery. Secondary prevention. And secondary prevention tells us that statins lower your overall risk by about 30% or so. Same is true perioperatively. They lower your risk of having an MI or death. And if they're a statin, if they've never been on a statin, I would start it pre-op for sure. Because the effect on the vasculature can be almost immediate. If I take some of our fellows to McDonald's and we have a big meal and supersize the fries and a big soda, and we measure forearm resistance, it's reduced within an hour of the meal. If I give them a statin and we do it the next day, it's mitigated. Vascular resistance is affected by a single dose of a large amount of statin. It's amazing. So it's way beyond the LDL. It's on vascular function. This is a study looking at fluvastatin versus placebo and vascular surgery. Big benefit. Another article by Polderman's, New England Journal. And then he did another study where he said, well, what about beta blockers and statin? And look at that, about a 2/3 reduction. When you look at that result, you're thinking, that's almost too good to believe. And you'd be right. It's too good to believe. Dr. Polderman's is our lesson in research fraud. People in Europe who are doing trials with him began to worry that the results were too good and suggested that perhaps the primary data should be reviewed. And what happened was his committee, his university formed a committee to review all of his trials. And they considered the conduct of the studies to be negligent and scientifically incorrect. Wow. And what did they find? So decrease 1, the effect of beta blockers wasn't even investigated, it was all made up. Decrease 2, fictitious method of establishing the outcome. No source data for decrease 3. The hospital events didn't match what he put in the database. Falsified the method of risk stratification, all of them. I've never seen in my life in cardiology an area that was so affected by research fraud. Study after study after study, New England Journal, and a lot of it was false. It's a lesson for those of us who supervise younger people doing research. We must be sure we're seeing the source data. When we see results that look incredibly promising, it's probably always used to ask the question, is it true? It's been estimated because the POISE investigators used fictitious methods. I'm sorry, they used Polderman's data to derive the amount of beta blocker they gave. That led to the deaths of about 40 people. So research fraud leading to a big clinical trial with mortality. The opposite of what we're trying to do in medicine. Statins overall definitely reduce the risk, particularly in vascular surgery. Okay. So I think patients who have atherosclerosis should be on a statin. And that's whether it's a calcium score or prior MI or stroke, heart attack, CABG, they should be on a statin. What about aspirin? We thought that maybe being on aspirin would reduce the risk of coronary thrombosis. Makes sense. And the POISE investigators studied this, 10,000 patients, 0 benefit on mortality, but there's some bleeding from aspirin. So on average, probably not. But interestingly, in POISE 2, it looked like the group with PCI, angioplasty within 5 years, might get benefit. But that's old technology. That's not new technology. And 2 weeks ago at the ESC meeting, a group of investigators published a study asking the question, if you've had your new drug-eluting stent more than a year ago, is it safe to stop aspirin perioperatively? The answer is yes, it's safe. And in fact, there's less bleeding if you stop. This is an example of how the stent technology and perioperative procedures around coronary angioplasty have just become much, much, much better. What about clonidine? Clonidine for years was touted as potentially lowering perioperative risk. It was studied in 10,000 patients, no benefit at all. But there is some hypotension, hazard rate of about 1.3, and bradycardia, hazard rate about 1.49. Clonidine should not be used perioperatively. What about using a PA line? Well, it was studied in a nice trial, almost 700 patients. No effect of a PA line on mortality. Might be a few more pulmonary emboli if you leave a catheter in the pulmonary artery. So there's no evidence that routine hemodynamic monitoring for very high-risk patients lowers risk. Probably should be done on an as-needed basis when you're in trouble. Okay, so now we're getting to the meat of it, aren't we? This is my confession. I was trained to think that we should find your coronary artery problem and fix it. And by doing that, we would lower your risk for non-cardiac surgery. We built a whole industry on that. Part of the CVC might have been built on that. Basic plumbing 101, find disease, fix disease. So Eagle and company published articles like this. If you're having non-cardiac surgery and you've had a bypass operation, look at the reduction in outcomes. Wonderful. Now, of course, to get into the study, you had to survive the bypass. Oh, yeah, right. Not randomized. Take it back. Maybe it's not helpful. So what about immediate revascularization? This has been studied. I like to fish. Any trial named after a fish, I'm going to love. And this is carp. This is a study in the VA where patients with vascular disease who had coronary disease got a cath, and 500 of them, they had stable coronary disease, got randomized to get fixed or not before vascular surgery. And the revascularization was the best that Victor could come up with. Cabbage, okay. PCI, okay. Whatever you think will be best. And then later they'll have their vascular surgery. These are veterans, dominantly male, 65. They had a lot of disease, angina, MI, heart failure, diabetes. The typical operations that our vascular surgeons do. They had good EFs. They didn't take patients with EFs of 20. And if you look at what type of surgery they had, a lot of them were on beta blockers for their heart disease. Many were on statins. There was no effect of this treatment on outcomes at all, perioperatively or long-term. 6 years, the survival curves are overlapping. Stable coronary disease does well, even facing vascular surgery. Unstable, not the same thing. All right? Kim Eagle thought fixing these arteries would improve outcomes. He was wrong, totally wrong. So in my journey, 30 years plus, we've shown that not only do beta blockers maybe not work, they may cause harm. No benefit of aspirin, no benefit of clonidine, PA line, no. PCI cabbage, no. Statins probably work. Holy cow. A big piece of my CV is that is true. We didn't know. We didn't know. So stent thrombosis, thankfully these days, if you've had a prior stent, the likelihood of having a problem if you have non-cardiac surgery is really low after you get out about 3 months. You see the red is the newer drug-eluting stent, and this is like 10 years ago. And if you look at patients who have perioperative cardiac events who've had a prior coronary stent, if the stent was placed more than 6 months ago, there's no hazard at all. Not at all. So patients who've done well following a coronary stent, either for stable or unstable disease, generally are going to do well, particularly after 6 months. Okay. I'm going to go by this in the interest of time. I will go back to this one. So SGLT2 inhibitors. This is coming up a little bit more. Obviously, these can cause euglycemic diabetic ketoacidosis. We generally want to stop these agents a few days before non-cardiac surgery. Okay? This is an important, fairly new part of our perioperative assessment. The GLP-1 agonists are around us, aren't they? And they slow down gastric motility. So if you are going into a non-cardiac operation with a full stomach, that might not be so good. So we want to stop these before non-cardiac surgery that's elective. If we haven't, then you might want to do an ultrasound to confirm that the stomach is empty. Okay? An important thing that we're starting to encounter now. So who needs a coronary angiogram? It should be patients who you would do that on anyway. If Victor comes with new onset angina, he probably should have that defined before we fix his knee. Right? But if he's been stable on medical therapy for 5 years and very active and without symptoms, we don't need to go looking. He's showing us stability and cardiovascular reserve on a daily basis. So high-risk surgery and multiple markers and poor functional capacity, that's a group we're interested in, but they're rare. The number of patients now that I would do a preoperative screen on is like way less than 5%, probably closer to 1%. Okay, what about biomarkers? Are we poised to repeat history? Troponins predict risk. This is non-cardiac surgery, and if you have a high troponin, then your risk of a problem is elevated. Okay, how does Kim Eagle treat a high troponin? Well, he takes a history and physical, for starters. They're trying to figure out, does this patient have heart disease or not? It's just a test, right? It's a test. We know that biomarkers have hazard rates in the 2 to 3 range, depending on which you choose. But do we really know in a patient who's stable, who has a modest elevation in troponin, what to do? I don't think we do. I don't think we know. And high sensitivity troponin, this looks at the troponin increase and the likelihood of a cardiology consult. So our cardiac fellows know all about this, right? Are any of you fellows or former fellows? Yeah. So you're chasing troponins all around the hall. They're everywhere. The clinical history, an EKG, not just one lab test. And how to treat the patient differently, we don't know. I love this quote by Bob Jesse. He used to run the VA cardiology. He said, when troponin was a lousy assay, it was a great test. Now that troponin is a great assay, it's a lousy test. Because it's so sensitive, isn't it? I mean, if you're in a little bit of heart failure, you're leaking troponin. Does that mean you have an unstable plaque? I don't think so. I don't think so. So less is more. Here's a very interesting study. Do I have time? Yeah. If you were going to design a human laboratory to study coronary plaque disruption and outcomes after non-cardiac surgery, you might do this. Take a human who has a stable plaque and blow up a balloon. And then after that, bleed them, give them pain, sedate them like heck, sleep deprive them, and give them Ringer's lactate. Right, Peter? Yeah. That's called what we used to do. It's interesting. When I came to Michigan in 1994, I had just recently chaired the national guideline talking about cardiac risk of non-cardiac surgery and how we should be parsimonious in screening. At Michigan, we were screening everybody. These are patients having a AAA. That's the first year, 1994. And then we said, well, we're not going to do that anymore. We're not going to screen everybody. So stress testing went down. You see, we had angioplasty and CABG drop by 90%. The length of stay dropped by a week. Holy cow. And some of my colleagues in anesthesia said, you know, what's happening here? You're killing people. You're not screening them. We're not treating them. And when we looked at the data, actually, the number of deaths or MI sort of dropped. I think we were causing MIs. You're taking stable disease and making it unstable and putting in that human lab. This is a study Jim Freilich did. Well, that's my confession. We were probably hurting more patients than we were helping. So prediction is very difficult, especially about the future. Nobel Prize. I love that. Remember Dan Quayle? He said the future will be better tomorrow. I don't know if that's true. I'm not sure. I like this one. Trip on Air Force One, $1 million, a new suit, 6,000, a jacket, 500, bulletproof vest, that's 6,000. Your former commander-in-chief looking at the troops with his binoculars and the lens caps are on. Oh my God. I can't see anything. Don't let the perioperative lights blind you to logic. History, physical, appropriate testing. I like this quote by Osler, medicine's an art of uncertainty, a science of probability. And I like to just honor the mentors who've been such an important part of my life and the support structure that I've had, especially people like you. You know, I've come through these doors every day for 30 years. It's been the greatest professional decision of my life to come here. And my decision to come in here every day is continually confirmed by the energy and the compassion and the innovation and the excellence that I get to work with, which are people like you. So thanks for the chance to talk, and be happy to take a question or two. Thank you.
Thank you,
Yeah,
Dr.
Peter.
That was a great talk.
Yeah, thanks. Kim, that was great. I really was glad I was able to make it today because I followed your work since I was general surgery chief and started applying both beta blockers and your risk scoring system well before I became a vascular attending. I'd like you to comment maybe just a little more. I tend to like and use the biomarkers in addition to history and physical. So it's patients that I might think should be able to need a cardiology consult or a stress test. And if I've found some patients who have NT-proBNP in the thousands,
Sure.
and then I'll refer them to cardiology to get assistance. So that's where I find it most helpful to obviate a dobutamine, echo or stress volume, et cetera, to try to streamline
Sure.
it a little bit.
So I think that the question is, does sort of routine measurement of either a pressure biomarker or a coronary biomarker lead to better care? And I don't know the answer to that. I think in context, if it's a patient who's very inactive, they have an abnormal EKG somehow, you really don't understand what their physiology is like. And especially if you're considering a very big operation, that thinking about what type of testing might move you is appropriate. You're using the biomarker to decide to get a cardiologist involved, which makes perfect sense to a cardiologist. But I don't know of data supporting that. I know that having a high proBNP or BNP predicts risk. I'm not sure how much lowering it lowers risk, but finding heart failure before you do something elective is smart. I just don't know exactly where it all fits. Okay, it's a good question. David.
Just marvelous, inspired as always.
Thank you.
And we're lucky to have you. So question, it's wonderful to see that statins with their pleiotropic effects, probably the only thing on your list that really reduces risk.
Yeah.
What do we know about the newer agents, which work completely differently, like the PCSK9 inhibitors?
Yeah.
Did they reduce perioperative risk?
So I don't know the answer to that. I haven't seen a single study. I don't know if any of you have seen a study looking at that question. None that I'm aware of. And of course, PCSK9s have been added to statins. I mean, we don't have good studies looking at them alone. They're an additive drug to statins, maximally tolerated doses. So whether bempedoic acid or inclisiran would do this and how quickly would the benefit occur, I don't know. Great question.
Dr. Eagle, I have a question if you don't mind.
Please.
So I always find it interesting about, the medications that we should give, but also the ones that we should probably stop. You mentioned SGLT2 inhibitors, GLP-1 agonists. Where is the balance between delaying surgery, especially if you're in the hospital? GLP-1s are given most of the times once a month versus, for example, doing what you mentioned, like doing a gastric ultrasound, or in the case of the SGLT2 inhibitors, doing a VBG after the procedure. Where's that balance?
Yeah, I don't know the answer to that question, Victor. And I think the anesthesia community and the surgical community is wrestling with this. So is our cath lab, right? I mean, even our cath lab sort of say, what do I do if you're getting, Jardiance the day before a cath? Do we want to delay the procedure? So I don't know the answer. I mean, I think certainly if you look at GLP-1 agonists, if they're getting twice a month shot, as you get toward the end of the 2 weeks, you're probably safe because the effects are greater earlier. But I don't know the right answer to that. A really good question. Yes, sir.
Yeah, thank you for the talk. And what is your approach, or how do you navigate this pre-op risk assessment in people undergoing solid organ transplant evaluation when, these people are high, particularly liver and kidney, they're high risk, but that revascularization kind of often doesn't improve outcomes. But you have a transplant team, they might say, hey, we're not going to offer them an organ unless you cath them. Or
Yeah, what a great question you're asking. And Nicole Bave has been working a lot on that. And there's a scientific statement, I think, that the AHA published a couple of years ago, which specifically targets that. I think we've had sort of the approach that if they're inactive and we're worried about coronary risk, that stress echo, dobutamine echo is a non-invasive, non-radiating, not too sensitive test that might find the bad coronaries, if you will. That's reasonable. There are some places in the country that require a cath, even now. So there's a lot of debate about that. Ted, do you have anything more to add to that? No.
Yeah, I agree exactly with what you said, Kim, and I think it's unclear. And I know, like, for patients, for example, with liver failure, too, even the interpretation of dobutamine echo can be more challenging because these patients are oftentimes very hyperdynamic, they're vasodilated, so on too. So to your point, your specificity is pretty high. Sometimes they get concerned the sensitivity may not be enough, and so they look for other testing, whether it's a nuclear stress test or in some cases cath.
Okay, thank you. Excellent. Well, enjoyed it. Thank you again.